Pharmacokinetics describes what the body does to the drug. This journey is summarized by the acronym L-ADME, which stands for its liberation, absorption, distribution, metabolism, and excretion. Absorption is specifically defined as the movement of a drug from its site of administration into the systemic circulation. The process of absorption is influenced by several key physicochemical factors. First is lipid solubility, also known as lipophilicity. This is governed by the lipid-water partition coefficient. More lipophilic drugs cross biological membranes more readily, following the rule that like dissolves like. Next is molecular size and weight. Small molecules, generally 500 Daltons or less, diffuse easily. Large molecules like proteins or monoclonal antibodies have very poor passive diffusion. The degree of ionization is critical and is determined by the drug's pKa and the local pH via the Henderson-Hasselbalch equation. This equation determines the ratio of ionized, water-soluble drug to unionized, lipid-soluble drug. Only the unionized form can passively diffuse across membranes. Finally, drug solubility and dissolution rate are fundamental. A drug must be in solution to be absorbed. For many oral solid doses like tablets and capsules, the rate-limiting step is the dissolution of the drug into solution, not the actual absorption itself. Drugs cross biological membranes through several mechanisms. Passive diffusion is the most common. It is driven solely by a concentration gradient, is non-saturable, and requires no energy. It favors small, lipophilic, unionized molecules. Facilitated diffusion is carrier-mediated, moving down a concentration gradient. It is saturable and selective but does not require energy. An example is transport via glucose transporters. Active transport is also carrier-mediated but moves a drug against its concentration gradient. This requires energy in the form of adenosine triphosphate, is saturable, and is highly selective. Examples include P-glycoprotein, efflux pumps, and peptide transporters. For very large molecules, such as the vitamin B12 complex with intrinsic factor, absorption occurs via endocytosis or pinocytosis. Routes of administration are broadly categorized. Enteral routes involve the gastrointestinal tract. The oral route, or per-OS, is the most common, convenient, and non-invasive. Its limitations include variable absorption, food effects, gastrointestinal degradation, and first-pass metabolism. The sublingual route, under the tongue, allows for rapid absorption via the oral mucosa directly into the systemic circulation, bypassing the first-pass effect. It is used for drugs like nitroglycerin. The buccal route, between the cheek and gum, offers similar advantages. The rectal route is useful if a patient is vomiting or unconscious, or for a local effect. It offers a partial bypass of first-pass metabolism as drainage goes to the inferior vena cava. Parenteral, or non-enteral, routes bypass the gastrointestinal tract. The intravenous route provides 100% bioavailability and an immediate effect, as it bypasses all absorption barriers. It is used for emergencies, precise dosing, or for irritating drugs. The intramuscular route involves injection into muscle. Absorption depends on blood flow at the site, with the deltoid faster than the vastus lateralis, which is faster than the gluteus. Depot formulations for sustained release can be given this way. The subcutaneous route involves injection under the skin, leading to slower absorption than intramuscular due to less vascularity. It is used for insulin, heparin, and some vaccines. The intradermal route injects into the dermis, as for a tuberculin skin test, resulting in very slow absorption. Other important routes include inhalation or nebulization. This provides rapid absorption via the large alveolar surface area and direct delivery to the lungs for respiratory diseases, like albuterol, while bypassing first-pass metabolism. The topical or transdermal route is used for local effects with creams or for systemic delivery via skin patches, such as nicotine, fentanyl, or nitroglycerin. This avoids first-pass metabolism and gastrointestinal degradation. The intranasal route allows for rapid absorption via the nasal mucosa, as with sumatriptan, desmopressin, or naloxone, also bypassing first-pass metabolism. A core concept is bioavailability, denoted by the letter F. Bioavailability is defined as the fraction of an administered dose that reaches the systemic circulation unchanged. By definition, intravenous administration has a bioavailability of 1, or 100%. It is calculated by comparing the area under the plasma concentration time curve for an oral dose to that of an intravenous dose, factoring in the doses given. The formula is F equals the area under the curve oral divided by the area under the curve intravenous, multiplied by the dose intravenous divided by the dose oral. Factors that reduce oral bioavailability include incomplete absorption, first-pass metabolism, chemical instability in the gastrointestinal tract, and efflux by transporters like P-glycoprotein. This leads to the critical concept of the first-pass effect, or pre-systemic metabolism. This is the extensive metabolism of a drug in the liver and gut wall before it reaches the systemic circulation, and it is a major cause of low oral bioavailability. Sites of first-pass metabolism include the intestinal lumen via acid hydrolysis or bacterial enzymes, the intestinal epithelium via enzymes like cytochrome P453A4 and UDP glucuronidosyltransferases, and primarily the liver via the portal vein. The clinical consequence is that significantly higher oral doses are often needed compared to intravenous doses, as seen with morphine, propranolol, and verapamil. Strategies to bypass first-pass metabolism include using alternative routes like sublingual, buccal, transdermal, rectal, or inhalation. Several factors can modify gastrointestinal absorption. Gastric emptying and intestinal motility are key. Faster gastric emptying generally increases the rate of absorption for most drugs. An exception is drugs primarily absorbed in the stomach, like alcohol. The presence of food and changes in pH can affect absorption. Food can delay the rate of absorption but sometimes increase the total extent of absorption. Antacids that increase gastric pH can alter the absorption of weak acids and bases. Drug-drug interactions also play a role, such as adsorbents like cholestyramine binding to other drugs, or chelation reactions like tetracyclines binding to calcium, magnesium, or aluminum in antacids. Inhibitors or inducers of P-glycoprotein can also significantly alter absorption. Understanding absorption has direct clinical application and therapeutic implications. Choosing the correct route is paramount. For an emergency, use intravenous. For convenience and maintenance, use oral. To bypass the liver or achieve rapid onset, consider sublingual or inhalation. The concept of bioequivalence is also based on absorption. Generic drugs must demonstrate a similar rate, measured by maximum concentration and time to maximum concentration, and a similar extent, measured by area under the curve, of absorption as the brand name product. Finally, understanding absorption kinetics is essential for maintaining plasma drug concentrations within the therapeutic window, thereby maximizing efficacy and avoiding both toxicity and subtherapeutic treatment. Thank you for watching. Don't forget to like, share, and subscribe. See you in the next one.